We'll get back to Professor Garg now. Sir, in your experience, what are the type and pattern of jaundice patient you have been observing in your clinical setting?
In fact, in our clinical practice over last 2-3 decades, we see both benign obstructive jaundice and malignant obstructive jaundice. When I say benign, means because of stone disease or once in a while because of worms. And when I say malignant jaundice, means because of obstructive jaundice because of malignant obstruction, like carcinoma head of pancreas or periampullary carcinoma, cholangiocarcinoma. We do see patients of obstructive jaundice because of secondaries at the porta hepatis. That's the pattern we see. If you really ask me the percentage wise how is benign and what is the percentage of malignant obstruction, I'll say it is 50-50. The only difference is that all patients of benign obstructive jaundice, we are able to bring out a complete cure by way of surgical treatment. But as far as malignant obstructive jaundice is concerned, what I have seen, and most of the practicing surgeons would have also seen, and the residents who are seeing and receiving training in their hospitals must have also seen, that by the time the patient comes to our clinic, it's far advanced, and radical cure is not possible in all. Very limited number of patients are radically curable. So in these patients we are only able to give some palliation, some kind of palliative treatment is given. So that's the answer to your question.
Okay. I understand a jaundice patient may be requiring some special kind of precautions. What are the precautions you are observing while operating upon a jaundice patient?
Yeah, those patients who are in for either radical surgery or curative surgery or palliative surgery, they are not like routine patients who are undergoing major surgery. Jaundice, as Dr. Rajesh has just pointed out in his slides, virtually affects each and every system of the body. While operating on a patient whose all the systems are affected in one or the other manner, we as a surgeon have to take precautions, particularly in an obstructive jaundice patient, on number one, the coagulation profile. We ensure that the patient's PTI and PTTK are all within acceptable limits, and this is achieved by preparing them by giving vitamin K sufficiently in pre-operative phase. The second important aspect that a surgeon has to address to in these obstructive jaundice patients is the renal function. Actually, we ensure that these patients are nicely rehydrated. Has been rightly pointed out by Dr. Rajesh that role of mannitol or diuresis in pre or perioperative phase is now gradually going to the backside. What is important is good hydration by way of IV fluids is very, very important. Kidneys should be kept flushed, and the third thing is that these patients, for these patients we keep fresh frozen plasma ready, and if at all the patient requires blood, our attempt is to arrange blood as fresh as possible for these patients. And of course antibiotic, nutritional care, routine post-operative care as you give for any other major surgery, that is same, barring for these 3 points, that is coagulation profile, renal hydration, and arrangement of fresh blood and fresh frozen plasma.
And once a patient is infected with who's suffering from jaundice and who's operated upon, what is the usual time lag between surgery and recovering to the normal phase?
Oh, that's a very good question actually. A patient who's having serum bilirubin of 13-14, or sometimes in malignant obstructive jaundice we see even up to 40 mg%. What I have observed is, and should be so also, that those who have obstruction of a short duration, if you relieve their obstruction by way of surgery or by some method, they recover faster within 5 to 7 days time, maybe maximum 10 days. their serum bilirubin comes down to normal level. But if the patient is having obstruction of long standing duration, chronic obstruction, even the patients of stone carry on the obstruction for very, very long time. So the initial bilirubin will fall fastly for about 5-7 days. But then to come to an anicteric level, to a normal serum bilirubin level, they take generally long time. And I put the pathophysiological aspect behind it. The chronic the obstruction, the more is the back pressure on the intrahepatic biliary system. The more the back pressure on the intrahepatic biliary system, the if there is a high pressure, the liver stops forming bilirubin. What you call as white bile is seen sometimes in chronic obstructions. So as the back pressure is rising day in and day out, the chances of recovery or the days for recovery gets prolonged.
But I am an alcoholic patient and I am unable to control my alcohol intake. So are there any specific instruction for a patient who has been consuming alcohol for over a long period of time?
In fact, alcohol leads to, I will say, one surgical disease, that is pancreatitis. And of course, some patients of pancreatitis do have some jaundice sometimes. The alcohol directly affects the liver, causing cirrhosis. Once the patient has cirrhosis, the manifestations are absolutely different. We see that there is no direct correlation of alcohol and obstructive jaundice as such, barring few cases of acute pancreatitis in which because of inflammation there is a blockage of channel and obstructive jaundice is produced. Otherwise, if alcoholic develops obstructive jaundice, then of course the patient first priority is to get treatment for the obstructive jaundice, get it relieved, and alcohol is never a thing to be advised that yes, after the jaundice is relieved you start taking alcohol. Of course, then we will advise that you gradually taper it down so that one gets rid of this habit. That's all I have to say with regard to obstructive jaundice for alcohol.
Sir, would you like to add on a comment on obstructive jaundice? Anything which has been left out?
No, I think nothing has been left out. The topic has been nicely covered by Dr. Godara and by nice comments from Professor Garg. So I think the threadbare discussion has been there on obstructive jaundice, and this must be very useful for the listeners.
Thank you, sir. But Dr. Rajesh, during your presentation, I heard a terminology called pseudo jaundice.
Yeah.
Could you just highlight what is again this pseudo jaundice?
The pseudo jaundice is a false jaundice. Means the discoloration is same like it mimics jaundice. Discoloration is there like jaundice, but this is not due to bilirubin, because raised bilirubin we call jaundice. This is not due to bilirubin, but this is because of some other substances like hypercarotinemia, the carotene injection, or some drug interaction like this quinacrine injection, or in a late stage uremia patient there is yellowish discoloration, and one should able to diagnose this even on clinical examination by examining the simple test like scleral examination, or at the most the simplest biochemical examination like bilirubin examination, rather than exposing the patient to so much irrelevant investigation. Only significance of this is that.
Thank you very much. I think we have come at the end of the stage where we have to say goodbye to our friends. Just to sum up, today we had maybe a little dry subject to offer to our fellow colleagues, but our panelists had made every attempt to make it more comprehensive, more lucid, to present in a simpler and using photograph and pictorials. I thank all my panelists for a deliberate attempt which have they made on the topic. And just to inform my fellow colleagues that National Board has been publishing journals on a regular basis, and I will invite upon all the consultants, all the faculty, all the postgraduate students to share their articles, their commentaries, their experiences with their fellow colleagues through this journal. National Board has also been developing this newsletter wherein we have been bringing out new activities to inform our fellow colleagues in the field of National Board. And as you are also aware that National Board has been preparing learning material in various formats, especially the DVD, which are being made available to candidates at a reasonable cost. I think that's it from my side. We'll say goodbye and meet in our February sessions. Thank you very much.